cure, we know that. We can only contain from adolescence to menopause. This goes on. And we have to have a better understanding. We have three eminent speakers with us who are going to tell us what can be done to alleviate the various symptoms with which these women suffer. So may I now invite Dr. Kadambari, who has been my colleague and a friend, to deliver her lecture about what to do in the adolescents. You can introduce Madam Kadambari.
Good evening, everybody here, all the ladies and few precious gentlemen who are sitting here. And Dr. Kadambari, I think, does not need any introduction. She is a calm, quiet, competent, confident, committed person, yes, who walks in her own style. There wouldn't be anything wrong if it suddenly came to my mind if I say Tennyson, she walks in beauty like the stars of cloudless climes and starry skies. But behind that silence, there's a very strong person, believe me. She has got the strength of her personality, she has the conviction of her knowledge, and she's very honest. And she will stand up.
Thank you.
And it's a privilege for me that I have a very, very long association with Kadambari. I cherish it and I'll continue to cherish, and we will hopefully be together in all these occasions. So here is Dr. Kadambari. She will be a fascinating person to talk about a fascinating, frightening endometriosis. Thank you.
Thank you, Dr. Sultana, for all those words. I'm too overwhelmed. I don't know what to say. But anyway, I have to say something about endometriosis in adolescents. Endometriosis, as Dr. Balamba has said, is enigmatic. I also say it is mysterious. Mysterious because we do not know the cause, we do not know the treatment. And when it is occurring in adolescence, we are faced with two problems. One is of the age, the other is the problem. Adolescence, as per WHO definition, is transition from childhood to adulthood. And in the world, there are more young people today than ever before. Out of the 7.2 million, there are 3.4 million young people. And if you take India, 243 million are adolescents. The world over, the adolescent population is 16%, but in India it is 25%. Why I'm quoting these statistics is to just impress upon you that we have a lot of disease burden and we have lots of adolescents who are suffering from this disease. And the disease itself is a chronic one, and we have to look at endometriosis in a different perspective. This picture shows the definition of endometriosis, which we are all used to. Presence of endometrial stroma and glands outside the uterine cavity. But to get at that diagnosis, what do we need to do? We need to do a surgery, we need to do a biopsy. And therefore, it is not possible to subject so many adolescents with these problems for laparoscopy. First is affordability. Second most important thing is acceptability. Even if we offer laparoscopy, most of the adolescents and their parents might refuse. So what is the solution? Solution is we have to look at endometriosis in a different perspective. Endometriosis, we have to look at is a chronic disease. It's an inflammatory disease. It's an estrogen-dependent disease. Now, what are the concerns of endometriosis? Endometriosis is a hidden disease. Symptoms do not correlate with the extent of the disease. Minor lesions can give rise to maximum symptoms. And even if we do laparoscopy sometimes, The endometriosis is hidden behind the peritoneum, and it's a progressive disease. Whenever they have done follow-up of those adolescents who were surgically confirmed to have endometriosis, they have found that number of them, 30 to 40%, continued to have the disease, or 10 to 20% continued with the disease in an exaggerated way. And it's a severe disease because it is associated with other very, very important causes. Like, for example, in adolescents, endometriosis is associated with uterine tract anomalies and other systemic disorders. And therefore, we have to look at the disease in a more broader way than we have been doing all these years. And adolescents, the commonest symptom is dysmenorrhea. And the patient suffers from dysmenorrhea, and because of this age, she doesn't know that it is abnormal. And the mother also tries to think it is a normal phenomena of menstruation, because primary dysmenorrhea is very common in the population. It is anywhere between 70 to 90%. And with that being so common, it is understandable that they do not approach the healthcare people for diagnosis. And when they come, we do not have any findings to account for the disease, account for the symptoms. And we just give some treatment, whichever we are following, like NSAIDs, oral contraceptives and all. Sometimes they respond, sometimes they don't. And sometimes we gynecologists are reluctant to offer laparoscopy in this age group, thinking that maybe they will be relieved with the medical treatment. And what are we doing by showing this much of compassion? The disease is progressing. The patient is suffering. Now, it is common knowledge that endometriosis presents with pain and infertility. We are looking at the disease with a tubular vision. We are only looking at the disease causing pain, causing infertility. But what exactly is happening is much more than these two symptoms. The quality of the life of the adolescents is compromised. She is absent in schools for the whole period of menstruation. She is absent in the career, and she is avoiding social functions. And apart from all these days, this disease causes a lot of anxiety, depression, sleep disturbances. The whole quality of life is compromised. And therefore, we have to take the disease seriously. Now, how frequently we see the endometriosis? Prevalence, we cannot judge in the population because it needs surgery to diagnose. And what information we get is those patients who have been subjected to laparoscopy for various reasons. And if we take the statistics, the patients who were subjected to laparoscopy because of chronic pelvic pain, anywhere between 50 to 75%, and with no response to medical therapy, if we take additional parameter, it is 50 to 75%. And infertility, it is 50%. And adolescents with chronic pelvic pain, around 40% of them suffer from endometriosis. The true prevalence is less clear because sometimes it is asymptomatic. And when it is symptomatic also, the presentation is so atypical that we are not able to diagnose even at laparoscopy. What causes endometriosis? We all know all these theories. I'm not going into these details. Like Sampson's theory of retrograde menstruation, the most common cause, uterine tract anomalies, proves this point. Coelomic metaplasia, environmental factors, there are so many other factors which all of us know. But what is new? There is a hypothesis put forward by Brosins that neonatal uterine bleeding might be one cause of endometriosis. We all know some female infants have bleeding in the neonatal period, and it is suggested that at that time the progenitor cells, the stem cells of the uterus, are thrown back into the peritoneal cavity, and these are stimulated at the time of menarche. And sometimes we see pre-menarcheal girls also having endometriosis, could be because of this. And very interestingly, the neonatal uterine bleeding is much more common in females who are growth retarded and mothers who had hypoxia, PIH, IUGR. So, this problem of intrauterine hypoxia goes much more beyond the growth restriction in the baby. So, uterine stem cells could be one of the causes. Neonatal uterine bleeding is supposed to occur in about 5% of the newborns. So, whenever we have a patient now with this knowledge, we have to ask whether the mother, whether the baby had bleeding. So, we can have some insight into this problem. Other risk factors are there. Earlier menarche, whenever the peritoneal cavity is exposed to lot of menstrual blood, and that occurs earlier menopause, nulliparity where there is no interruption of pregnancy, shorter menstrual cycles, menorrhagia, and these two I have put in yellow because I wanted to draw your attention. It is childhood sexual abuse and physical abuse. How it causes, it's not known, but maybe the stress of these abuses causes the problem. And Asians, as Asians, we are more prone. And most important, the thing we have to remember when we are dealing with endometriosis is taking the family history. It is much more common when a first degree relative is affected, 7 to 10% in those patients who have a mother or a sister suffering from endometriosis compared to 1% in the general population. Symptoms of endometriosis, you all know: dysmenorrhea, dyspareunia, painful bowel syndrome, abnormal bleeding patterns. All these are very, very familiar to all of us, but we have to give special attention to the pattern of these things. Like dysmenorrhea, whether it starts with the period or before period or continues beyond the period, and dyspareunia, painful bowel movements, because the number of symptoms a patient has, the more chances that she is suffering from endometriosis. And apart from the history of dysmenorrhea, dyspareunia, dysgeusia, and bowel movements and urinary frequency, we also have to elicit the history of associated symptoms, because this is very important. As I go into the next slides, I will show you whether it is not associated with nausea or vomiting, and other gastrointestinal or urinary symptoms, headache, muscle cramps, poor sleep quality, just to assess the quality of life compromise over there, and recurrent short-term absenteeism, this all of us know. Whenever they have assessed the symptoms retrospectively in patients who have undergone laparoscopy, they found that 56% had gastrointestinal symptoms. And therefore, when we are eliciting this, typical all patients we cannot subject to laparoscopy. So, if we give more attention to the symptomatology, we will be more able to diagnose this condition. So, gastrointestinal symptoms are very common in adolescents. And even genitourinary symptoms, increased incidence of PMS, premenstrual syndrome, and incidence of anxiety and depression. So, whenever we have dysmenorrhea or dyspareunia or chronic pelvic pain with symptoms like this, it is more likely that we are dealing with a case of endometriosis. And now, after the symptomatology, how do we examine the patient? I am dealing with adolescents, so is pelvic exam required, or is it possible Some of them may be married because in our country child marriages are still common, and sometimes they are having already sexually active life. Apart from these two categories, all the other patients, maybe it is not possible to do a pelvic examination, but a recto-abdominal examination might help in assessing the pelvic organs. And a small cotton swab tip we can pass if we are suspecting a genital anomaly to know the vaginal patency. And what is important is clinical examination. We have to come back to the basics now, move away from our high technology methods, because this a clinical problem, a clinical diagnosis is what is required today. Focused clinical examination to rule out uterine anomalies or pelvic masses, genitourinary causes, inflammatory diseases, because these are all the conditions which give rise to the same symptoms. Symptoms are similar in all these problems, causes, and therefore clinically we have to rule out all the other causes of the other organ systems. Dysmenorrhea also is not confined to endometriosis itself. We all know congenital obstructive Mullerian anomalies, cervical stenosis, uterine polyps, fibroids, adenomyosis is not uncommon in adolescents, pelvic inflammatory disease following interfered pregnancies or sexual activities, and pelvic adhesions following any chronic inflammation of the pelvis can give rise to dysmenorrhea. So we have to be careful to rule out all these other causes of dysmenorrhea before we come to the conclusion that it is endometriosis which is causing dysmenorrhea. Now, most important aspect to rule out in adolescence is obstructive Mullerian anomalies, where such as imperforate hymen, transverse septum, all those anomalies where there is cryptomenorrhea, it is not difficult. Patients will come early, there is amenorrhea, there is cyclic pain going on to acyclic pain, you have masses in the abdomen. It's not difficult. But what is difficult is without obstruction, if there is an uterine anomaly, patient has regular periods, still has dysmenorrhea, unless we identify and release these obstructions, patient will not be relieved. So Mullerian anomalies like rudimentary horn with functional endometriosis. Uniconvate uterus is very common, but the other horn is usually non-functional. But whenever there is a rudimentary horn with a functional endometrium, these are the cases where there is likely to be endometriosis. And also a septate uterus with partial obstruction of the vagina. Bicornuate uterus with a hemivagina. So all these conditions where there is a partial obstruction, that is much more difficult to diagnose. But we have to keep in mind this problem. Like here, you see the bicornuate uterus with a vagina and a cervix, hematocolpus. And apart from the uterine causes, we also have non-gynecological causes of chronic pelvic pain. Chronic pelvic pain is that pain which occurs in the pelvis, and usually it is more than 6 months. So that's how we define as chronic pain is anything which is lasting more than 6 months. So what causes pelvic pain in women? There are other causes, like most important is irritable bowel syndrome and interstitial cystitis, and other causes like appendicitis. And it's very interesting to know that many of the patients, there will be a history of appendicitis in the previous history. So any history of pelvic surgery. We commonly see patients coming with already an appendicectomy scar, and with a chronic pelvic pain or acute pelvic pain, patient approaches the doctors, she is referred to a surgeon. Appendicectomy is done. Sometimes they don't find the appendix inflamed, and instead what they find an ovarian cyst, and that is removed. we do not know whether that was an endometriotic cyst or a simple cyst which underwent torsion. And apart from this history and clinical examination, what other investigations will help us to come to a conclusion? And these are routine tests. CBP ESR to rule out inflammatory process, a pregnancy test. If you are suspecting a problem of incomplete abortions or septic abortions, if they have PID, and a urinary examination to rule out urinary causes. What about CA125? It has no role in diagnosis of endometriosis. And what next we can do? We can do ultrasonography. Why should we do ultrasonography? It's mainly two causes we can rule out. One is ruling out adnexal masses to rule out reproductive tract anomalies. Here you see the typical ground glass appearance of an endometrioma. And other uterine tract anomalies. Here you see a bicornuate uterus. The left side uterus is hematocolpos. This is an ultrasound picture. Now if we have masses, either adnexal masses or a uterine anomaly, we can also ask for MRI. But MRI is not universally available, as we all know, only available in a few centers. But that is, if an anomaly is there, it will certainly help make things clear for us, better than MRI. Now we have a 3D ultrasound. We have experts over here who can take as beautiful, as clear pictures as MRI. But equipment and the persons are important. So this is another MRI picture showing hematometra and hematosalpinx, and these are the things, hematosalpinx and hematometra, they induce endometriosis. Endometriosis will be relieved after the release of the obstructions, but in some patients it persists. So that's very important. The peritoneum has been induced by these obstructions, so we have to remember that they can have in future endometriosis continuing. Now there is a beautiful article by Agarwal and all calling, it's a call to action, they named the article. Idea is to moving away from a histological definition to a clinical definition. So therefore, the clinical definition, we have to pay more attention to the symptoms, rule out other causes, and ask for routine investigations and do an imaging study. So we have to look at endometriosis as a chronic inflammatory estrogen-dependent disease. They have made an algorithm of each and every step where we can think it is endometriosis or other causes, like symptoms, like the family history, the examination findings, and imaging studies. What all I have told you, they have made it into an algorithm. It's very clear over there what other systems can cause the same problems. Now, why should we deal with endometriosis? Is clinical action is because for diagnosis, we all know laparoscopy is indicated, and laparoscopy is not approachable to many or accessible to majority of the people, and also they may not accept to undergo surgery for diagnosis and the simultaneous treatment. So by moving away from a surgical diagnosis to a clinical diagnosis, we are preventing a problem of central sensitization. This is where a chronic problem, if it is not interrupted, it sensitizes the central nervous system so that central nervous system overreacts to any other stimuli, and the pain the patient may perceive anywhere not connected with the organ itself. Dr. Alex, I came to know, he deals with these problems. I won't go into the details of these phenomena, but there is one problem, that is the central sensitization is one aspect of the disease which we have to understand. Now, when we suspect endometriosis, how do we deal with this problem? Now, the basic important aspect is to rule out other gynecological and non-gynecological causes. That's the most important thing. And then, after ruling out, when we think it is endometriosis, or when we clinically suspect endometriosis, we can treat, like what is the basis of moving away from histological diagnosis to clinical examination is to initiate treatment. And what treatment we initiate? Trial of NSAIDs and continuous hormone therapy for 3 to 6 months. Now, after this 3 to 6 month therapy with these two drugs, if there is no response, then laparoscopy has to be done both for diagnosis and management. Now we start with NSAIDs. We have lots of drugs over here. I don't want to go into the details of each and every drug. These drugs are effective. They have been in use for many, many years, and they are not very, cause they don't have much of side effects, and they're not expensive. They're cost effective. So even simple, nice guideline of 2017 says paracetamol is good enough. So we have to start with these simple drugs, but what is most important here is that we have to start the drugs, NSAIDs, before the menstruation starts. So unless we educate the patient about this aspect, now we have given the tablet, she has taken, and there is no response. But the response will be there provided we give it in time, in the proper dosage, for the proper duration. That is more important than what drug you give. Then we have to start the drugs 2 days minimum before the expected period. And if the patient is not sure of periods when she gets, we can start with the earliest symptom. So important thing is to start before the periods. You have the loading dose, twice the usual dose, and then start with 4th hourly, 6th hourly, whatever is the drug pharmacology says. So most important thing is you start before, give the loading dose, continue for 2-3 days, and the drug can be taken with food to minimize the side effects of gastric irritation, and we must tell the patient to take a lot of water so that the urinary problems or the urinary tract urinary problem do not arise. Now the second class of drugs is extended or continuous use of oral contraceptive pills. We all know the contraceptive pill combinations. I don't want to go into the detail of what contraceptive and all. Oral contraceptive pills are the next class of drugs that can be tried in endometriosis. Now we have ethinyl estradiol combination with the different components of progestins, like first generation, second and third. If we take the first and second generation norethisterone and levonorgestrel, they have more androgenic side effects. In endometriosis, we prefer a drug which is more androgenic, but because of the side effects, now the newer drugs like desogestrel, drospirenone and all, they also have equal effect, and they are less androgenic. But all these drugs, each one has its own potential complication, then we have to choose which drug will be better for that particular patient. Now oral contraceptive pills, we have to take care of the side effects. Very common side effects, you all know: headaches, nausea, bleeding, breast tenderness. And we have to warn the patient before so that she is aware of these side effects. And the most disturbing side effect of oral contraceptive pills is the venous thromboembolism. Of course, in adolescents, it may not be a problem because they are young, but if they are smoking and all those things, that it's not very uncommon nowadays, so we have to be careful. Then the next class of drugs is progestin-only methods. Progestin, instead of oral contraceptives, if they have a contraindication for estrogen, we can go for progestin-only methods. These are also very effective in endometriosis, like norethindrone acetate and medroxyprogesterone acetate, which we all been using for contraceptive purposes for so many years. We can give it oral, subcutaneous, intramuscular, and implants. And the newest class of drug is the Dienogest, which is given in 2 milligram dose. This is a progestin which is exclusively used right now for endometriosis, and has been in use. We also have used Dienogest for endometriosis in adults. But can it be used in adolescents? Trials have been conducted in adolescents for 1 year Dienogest, effective as in adults. But the concern of not only Dienogest but all these progestin only components is the bone loss. The problem of bone loss is very important when we are dealing with adolescents, because this is the period when there is a bone formation, and if there is a bone loss, she may be left with permanent osteopenia, and she may have risk of fractures later in life. So Dienogest also, along with other progesterones, causes bone loss. Most of these progesterones, they have bone loss around 1 to 2%, but one aspect is that after we discontinue the treatment, the bone loss recovers, but it doesn't recover fully. Suppose, for example, with Dienogest, 1.2% bone loss was there with 1 year treatment, but at the end of the treatment, after 6 months, the cortical bone density recovered 0.6%. That means there is still a deficit of 0.6%. It is not only Dienogest, but all, especially with the medroxyprogesterone acetate, also long-acting progesterone, we have this problem. And new addition to our armamentarium is levonorgestrel IUS. It is not contraindicated. That's what I want to stress. It is not contraindicated in adolescents, but only thing is whether it is acceptable or not. If we are doing a laparoscopy, it is recommended to insert at the time of laparoscopy so that the patient doesn't have another pain of insertion there. So it is another method available for control of endometriosis. It is supposed to be very good. I mean, we have used in adults but have not used in adolescents. But dysmenorrhea and rectovaginal pain, it is much more useful. But sometimes if the endometriosis is widespread, along with levonorgestrel IUSV, we may have to use other systemic drugs to counteract the other aspects of the lesion. Now, what is the role of GnRH analogs? Again, in adolescents, we have to think of the bone loss and hypoestrogenic symptoms, but definitely not under 16 years. Can be used in patients who are more than 16 years. You all know about the GnRH agonists, cannot be used continuously. But in cases of endometriosis, who are not responding to the first 2 line of drugs, NSAIDs, oral contraceptives, and other progestin components, we can try GnRH, but we have to add back immediately within the first week of GnRH. Like in adults, we wait for some time to add back, but add back simultaneously with the GnRH reduces the bone loss. But the bone loss with GnRH is very high, 4 to 5% compared to progesterones. And therefore, norethindrone acetate is the drug of choice for add-back therapy. There's one good thing about norethindrone acetate is one of the metabolites is an estrogen component, so they do not have estrogenic, hypoestrogenic effects. We can also use ethinyl estradiol along with MPA. And now we have a lot of complementary or alternative treatments available. We have to keep our mind open because this is a chronic disease. They may not be relieved with one class of drugs. And even if there is a relief, there may be side effect which becomes a contraindication. So therefore, there are lots of things like exercise, heat, food supplements like fish oil supplements, especially omega-3, they say gives a lot of relief in dysmenorrhea and chronic pelvic pain. So we have to keep our mind open, and if the patient has some relief with these methods, she is encouraged. And as long as there is no harm occurring from these agents, then we can try these complementary alternative treatments like in any other chronic condition, like acupuncture, yoga, fenugreek, ginger. All these things are there. So lot of things are there. We have to try them, test them. And now comes last but not the least is the surgical treatment. You know, surgical treatment is both for diagnosis and treatment. So you all know endometriosis requires laparoscopy for a definitive diagnosis. But whenever we do the definitive diagnosis, if there is endometriosis, we have to treat it simultaneously. We just can't go on just doing a laparoscopy and then counsel the patient for another sitting. So we have to take a pre-operative consent to go ahead with any surgery that is required at the time of laparoscopy. Fortunately, many of the lesions, many of the adolescents have early stage disease, like stage 1 and 2 of the ASRM classification. And they can be dealt with either ablation or excision. And what is most important in adolescent endometriosis is that the lesions are not the classic powder bone. They can be varying in color and they can be very subtle. That's the important aspect. Unless we know about the lesions, we will easily miss them, like white clear vesicles, red petechial hemorrhages. And we don't see the classic appearance of endometriosis we see in adults. Now this is early endometriosis. This we just last week only we did this case. I asked Dr. Prashant to be a little slow to demonstrate these lesions. And you see the clear white vesicles. You don't think it is endometriosis at first look unless we are aware such lesions are endometriotic. See, you go very near to the lesion. That is called a contact laparoscopy, so that you can clearly see. If you see from a distance, you will miss it. You see the increased congestion, the white vesicles, and somewhere around petechial hemorrhages are with. These are very, very early lesions, and these are the ones we can easily miss. So we call it as a near contact laparoscopy because of the increased high definition video cameras that you have, we can catch. Earlier reports of laparoscopy, they used to say the early endometriosis, they did not make out because of the technical problems. Now, you can also put in a green filter, what is putting as a green filter to make the lesion more clear, and also you can see the vessels very clear. And this is a spectra or green filter or whatever the name that system gives you. You have in your cameras that option. You can switch it on and see beautifully how we see red petechial hemorrhages and all. So this is, we need patience, we need knowledge to see, because what the mind doesn't know, the eyes don't see. So we have to know to see. I know these are the classic ones. Nobody will miss such things. And we have to go very gently. See that we are least traumatic. And this is one example of excision with a monopolar cut. So we have different instruments available, different energy sources available, like monopolar, bipolar, laser. Each one has its own complications. This monopolar we have been using for so many years. Only problem with monopolar is the surrounding area also is damaged. So now we have other option of a bipolar cautery, bipolar scissors dism, and excision of the lesions with a bipolar cautery. Now when you see this video, you can make out that the surrounding area is not black. If you use monopolar cautery, you see the surrounding area is very black. So that is charring of the surrounding areas, whereas with bipolar instruments, you don't see that charring. It is confined to the tissue between the two blades, and this is a bipolar forceps, not very expensive, can be used in such lesions for atraumatic cauterization or excision. So excision is better than cauterization, but in adolescents, one caution, extensive peritoneal stripping and excision is not recommended, because they have seen when they have excised the whole peritoneum or there, they had intestinal obstruction, and even if we put interseed or any barrier, also if the area is wide, they may have chronic pelvic pain persisting because of the adhesions. So in adolescents, we have to be little careful in excision of these extensive areas. Stage 3 and 4 lesions are less frequent in adolescents. About 2/3 of the lesions are early, and 1/3 of the lesions belong to stage 3 and 4. And the treatment in these conditions is same as in adults. Now here you see an example of an ovarian endometrioma. Along with some adhesions, you can see some blue nodules over the right ovarian ligament. And we have to be careful. Endometrioma, Dr. Prashant is going to talk in detail. I won't go into this aspect of surgery, but in adolescents, we have to be much more careful than adults in preserving the ovarian tissue. Endometriosis, I've been telling, is a long-term problem. It's a chronic problem. If you do surgery extensively, very happy, but we have to follow it up with medical therapy. And endometriosis is a chronic disease, and there is no definite cure. Neither surgery nor any medicine is going to completely cure. It's only under suppression. So the goals of therapy have to be symptom suppression, prevention of progress, and prevention of preservation of fertility. We have to use atraumatic techniques, irrigate copiously so that they don't form adhesions. You see surface endometriosis over there, and we have to lift up the ovaries to see the sub-ovarian adhesions and take all surgical steps. You see the peritoneal defect, and all these are manifestations of early disease. And now in endometriosis of adolescents, there are certain aspects you have to be careful when compared to adults. Then presentation in pre-menarcheal girls can happen. If the patient has some mass in the endometriosis, cannot be ruled out just because she didn't attain menarche. Pain with an obstructive anomaly of the genital tract is the most important component that we have to rule out. And endometriosis is associated with other diseases like migraine, and it can be very severe form. And also autoimmune disorders, they have an immune compromise, so they are more prone to autoimmune diseases like SLE, RH, and also thyroid disorder. So we have to look for all these associated diseases when we are dealing with endometriosis. And to conclude, ladies and gentlemen, I've been telling multidisciplinary team is one. You can think of pain management systems and psychological counseling, which will help the patient to cope up with the long-term problem of endometriosis. We as gynecologists, we are looking at endometriosis only with a tubular vision, like pain or infertility. But there are much more aspects of endometriosis, or the quality of the life, the sleep disturbances, with the psychological disturbances. So we have to treat the patient as a whole, and if we need any help from the other disciplines, then we should involve them. Laparoscopy is the only definitive method of diagnosis, and therefore to remedy the diagnostic delay, early intervention is critical, and treatment to be individualized to improve the compliance and decrease the side effects. Thank you.
Thank you, Dr. Kadambari, for a very extensive, illuminating, lucid, covering every aspect of endometriosis. It was wonderful. But we as chairpersons have failed to limit the time. That is our fault, me and Balamba, yes. Because it was such a wonderful thing. She has talked everything wonderfully well, and she has awakened us, and we have really freshened our memory about knowledge about endometriosis. But I'm sure Dr. Axel and others won't mind that we will say the best of your knowledge, concise, complete, in a limited time.
I'm sorry, I didn't realize the timings.
No, because it's not her fault. It's not her fault because we gave endometriosis as a whole topic to her, isn't it? Yes. Yeah. It is my darling dearest, very versatile, expert in gynec ultrasound, expert in imaging, surgery, talking. She comes, she sees, she wins, and she goes away. That's Mamatha. So I think because to hold the interest, thank you so much, wonderful. Now I'll give it to my co-chairperson, Dr. Palama.
I now call upon Dr. to deliver his lecture on how to manage ovarian endometriomas. We all know about him, a wonderful laparoscopic surgeon. What should I say, level 3, level 4, level 5, whatever levels are there.
I'm just an ordinary man.
With extraordinary skills. Yes, yes.
You may have the lights on, please. Yeah. No, don't do that. Can I have the lights on, please? On. Well, I'll try to be brief as I can and minimally invasive, but I always, they say he's very controversial, which I don't deny. And can I have the lights on? I like to see myself.
No, you want to see others?
I'll shut the lights when I start talking on the side.
At the same time, we want to see others.
Yes, exactly. So I actually wrote down what I haven't on the slide. A is, I was once called in when a very popular political gynecologist from India was addressing management of endometriosis, and she said, I was not attending the lecture because I don't normally attend such lectures. I started waiting outside for my turn, and she said that there's no role for laparoscopic surgery in endometriosis. How many of you all agree with her? Is there anybody?
To agree with politicians. You said she was a
Political gynecologist.
Yeah, political gynecologist.
Okay. So I was asked to comment, and I said, well, Lord forgive her for what she said, because what she does is right. Because in her hands, since she doesn't know how to operate, she's not doing any damage. By giving medicines, by giving medicines, at least she's not screwing up the patient. Okay, so thank you that you all agree with me. The other is also the fact that there are many ART specialists who believe that the infertile woman should get pregnant even if they don't have sex. And sex, ladies and gentlemen, is like food. It's very important for everybody. And if that is going to be painful and they can't have sex because of endometriosis, then how do we really treat them unless until we get that endometriosis out? So therefore, I come now to the topic of endometriomas, ovarian endometriomas as a solitary pathology does not really exist. Because if you believe in what Kadambi just showed, where you do a near contact laparoscopy, you will always find endometriosis in the pelvic peritoneum or the rectovaginal region. And why does that happen? That happens, why does the diagnosis not happen is because the clinician sometimes fails to even do a PV on the patient. They just stick the probe in and do an ultrasound. Or often they are referred to somebody else. And I've been trained in Germany, and Mamatha also does what I do. We are gynecologists. We should do our own ultrasound.
Yes.
Right? And therefore, the radiologist should be banned from doing ultrasound, because, as I always say, the woman's pelvis belongs to the gynecologist. Doesn't belong to the radiologist. Doesn't belong to the general surgeon. So even if the husband of the gynecologist is a general surgeon, he should stick to his wife's pelvis alone and nobody else. So therefore, I come now to discuss endometriosis and laparoscopic surgery. And we all go back to our teacher, that is Professor Sen. And if it was not for him, he was termed and dubbed as a surgical gymnast. He was put in jail in a psychiatric ward for performing a appendicectomy in 1980, reinstated back because they found the technique was right. Well, he was crazy. He was a crazy man, but he had a lot of brains. And if it was not for him, our entry into endoscopy would have been delayed by a couple of years. And Alan D. Cherney wrote this, that reproductive surgery by laparotomy is obsolete. And obviously, because the results with laparoscopy are much better, for reasons that are all known to you, and all reproductive surgery should be done by laparoscopy alone. Why? Because laparoscopy, you can shut the lights off now. Can I have the lights off? Yeah. So it gives us the advantage of good vision. You have got magnification. Now with the advent of 3D cameras, I use 3D in my private setup, but also now with the advent of 4K, which is available, you can get good information out of the pelvis. It enhances and homogenizes the quality of work. However, there are certain limitations, inconveniences, not limitations. You need to understand ergonomy. You need to have the ability to be having good productivity. So you should not be tied down with fatigue. Suturing requires skills. You need to understand your energy sources. So therefore, it's better to be prepared. So therefore, like anything in life, there has to be a strategy, right? You must decide how you're going to treat with this, deal with the problem. And that begins in your consulting room. You need to have can they put the slide off, please? They need to have a good clinical history. You have to have a triage of a history, examination with ultrasound. Now, I don't know how long it takes to examine a patient completely for endometriosis, but my son and I, who work together, we take about 45 minutes to do a complete examination with the history of a patient of endometriosis. Because even if she comes only complaining of infertility, we want to know whether she's having pain or not, when does she have pain, and where is the direction of the pain. So you need to do a pain mapping, which Axel is going to talk about later. And then we do our own ultrasound. We do not believe in abdominal ultrasounds, even if the patient is an adolescent. Of course, they are virgins, so you can't do a vaginal ultrasound, but you need a transrectal, for which you need to tell the patient to come prepared, or with a good bowel prep. Maybe we give them Dalcolax 2 nights, one night before the examination, and do an ultrasound that gives you a good idea of the ovary and also the rectovaginal region, right? So that gives us a much better perspective of doing the ultrasound while the ultrasound. So there have to be specific rules when one deals with strategy. You need to recognize the anatomy in the first place, because only when you look at normal can you go towards the abnormal. So even if you've got the ureter in close proximity to the ovarian endometrioma with the adhesion, so you need to know where your ureter is. So you start from the normal, that is, get above the pelvis, track the ureter down. You need not always dissect it, but you need to have good dissection skills to get down into the retroperitoneum and dissect the ureter way away from the ovary. So exposure and shaping of the image is very important. You need to have good dissection techniques. You keep the instrumentation very simple. I believe in my bipolar. I believe in the instrument that Kadambari did show. You hardly require to use the harmonic unless and until the patient can afford it and use it as a single-use product. And what's important is do not irrigate when you are trying to dissect out the tissue, because if you try to dissect out the tissue with irrigation, sometimes that fluid finds the plane of the cleavage where there's least resistance, and it can open up spaces where you really do not want to go. Right? I won't go through the details because that was also for a later lecture, but what's important is you need to keep the pelvis clean. So therefore, clear. So therefore, what we do is we prepare our patients preoperatively to see that the bowel has been well prepared. And we hardly get diagnostics in our theaters. It's always somebody who's referred or we have examined. The reason for doing the laparoscopy is mainly for surgery and not for diagnosis, because the diagnosis already is done in the clinical room and not in the theater. It only clinches the diagnosis. So you bowel prep by giving Peglac and Dulcolax 2 nights before surgery, get the bowel out, and therefore we always get rid of these adhesions that you can see. These are the congenital adhesions, because it's only when you release all these adhesions that are there on the left side that you will be able to then get access towards the retroperitoneum and the ureter and the other structures that may have been adherent either because of previous surgery or because of extensive endometriosis. So once you have dissected that, you then also need to move the ovaries away, and therefore you need to either suspend the uterus, either using a good uterine manipulator. We use the Valchev uterine manipulator, but sometimes if the patient is a virgin, you cannot do any vaginal manipulation, so we use either a straight needle or we use a curved needle. We now started using the curved needle with monocryl, or we use proline because it's just a temporary suspension, right? So basically you need to have suturing skills, and without suturing skills you really shouldn't be doing advanced endometriosis and advanced laparoscopic work. So you use this as a suspension. The device also available as a T-lift that is available, that was developed by Arnaud Wattiers. But basically what you're doing is you're lifting the entire uterus up, and that gives you a good exposure to the cul-de-sac. Right now, there you can see that the patient has an endometrioma on the side. You need to then go ahead with dissection. Now, if you have a patient who has got an endometrioma with rectovaginal disease, all that you first do is you decompress. You do not do the enucleation before, because it will start bleeding and it will hamper your plane in the region of the rectovaginal region. So suspension, so that you suspend the ovaries away. There are many ways to do it. One is using a straight needle, the other is using a T-lift, or the other is the one that we've developed to use as a reusable device to keep the ovaries away and suspend them. So this is one method. The other method I will just run into the next video, which is using a curved needle. So basically you have decompressed, and then you use a curved needle there and you fix it to the round ligament, and that way you keep the ovaries out. So that way your assistant can use both her hands or his hands to help you during surgery. Remember, laparoscopy is not a one-man show, it's a teamwork. So it's just not just you and your co-surgeon, but you also have a good vaginal assistant who needs to use the rectal probes and the vaginal uterine manipulator if required. So once the uterus and the ovaries are out, you can then work in the rectovaginal area. You can see there's a nodule there that needs to be addressed, right? So we are now coming back to ovarian reserve. By definition, the functional potential of the ovary, which is reflected as the number and the quality of the remaining primordial follicles at any given time. And as Mamatha rightly said, that it is the gold standard in the treatment of endometriotic ovarian cysts, and that excisional surgery is the way to go, is the best technique to prevent recurrences and improve some symptoms. However, if you're not careful and if you're not patient, if you're not perseverant in your surgeries, it may result in ovarian damage due to removal of normal healthy ovarian cortex. So coming back to the case of the unilateral endometrioma, I put this on because I'd seen a patient, and the patient sought a second opinion. I got a call from the ART specialist, this is Bombay, and they said, why do you want to do this surgery for endometriomas? This patient, I can aspirate the endometrioma during IVF and I'll get the patient pregnant. It's 3 years now and the patient is still not pregnant. All right, so because you can't really be doing endometriosis therapy at the time of your ART, nor can you get, and I'll talk about that in my slides. So the viewpoint, I would like to discuss this, whether you're going to go straight with ART or whether you're going to surgery. Fortunately, here in Hyderabad at Mamatha's hospital, we always treat our endometriosis before they go in for therapy, whether it is IUI, whether it is IVF. Right, so now coming back to the slide of shown by Kadambari, right? You're looking at that ovary, everything else looks very innocent. You see a few powder marks there, endometriosis, but that's just the tip of the iceberg. And as you go closer down, as you saw in the video that she's shown, you can see the very subtle endometriosis that otherwise would have been missed, except when you do a contact laparoscopy, near contact laparoscopy. So when we looked at some of the data where they talked about the unilateral endometrioma, and this is Benaglia in 2012, where they showed 84 women with unoperated unilateral endometriomas and no previous surgery. They were selected for IVF. Right? And the conclusion was that the presence of an endometrioma does not markedly affect the response to hyperstimulation in women selected for IVF. Now, coming to surgery for endometriosis, lots of things have been done in the past as well as in present times. Earlier on, people even tried to vaginally aspirate and drain the endometriomas. Some even felt like putting in a sclerosing agent. The moment you put a sclerosing agent, it goes into the cyst wall all right, but it also leaks out, and then you've got a good frozen pelvis for we endoscopic surgeons to work on. Right? So that's really something that one shouldn't do. You should not drain and fulgurate. It's not going to work. It's just the tip of the iceberg that you're dealing with. Some people like to do a fenestration and give GNRH because probably they've got shares in the company or they're getting kickbacks to take a cruise somewhere, or you do an enucleation. All right, so that comes to an age-old therapy that was described in 1982 by Kurt Sem, and he called it the sandwich therapy. That is a 3-step therapy. Many people have tried to emulate the same, and the same thing also was described in human reproduction as the combo therapy by our friend Done. And finally, of course, if there's no ovarian tissue that's left behind, or the patient has got recurrent endometriomas, right, then it's better that you do an ovarectomy on the one side and leave the ovary on the other side alone for you to get your results. Right, so basically what the 3-step therapy of Sen advocates is that you do the least damage, you just aspirate, do an initial adhesiolysis, and then you start with the 2nd-step therapy. And in those days, so that's basically what he does. He does the enucleation, and then you will then give the medical treatment. Now the medical treatment, I'll leave it to you what you all want to give. Dr. Kadambari has already spoken about it, right? One can try Dynogest, one can try Zoladex. I prefer to use either of these two. Patients do not like to be having medication every day. It's better to give a monthly dose of GnRH. Zoladex would be my preference, but again, everything else is just, it's interim. You want to reduce the vascularity, or sometimes when you put in a laparoscope and you find that the patient is a frozen pelvis with endometriomas everywhere, you touch and he starts bleeding, then you know that this is a case that should actually be given medical treatment before. So you give 6 doses of medical treatment, I'm talking about GnRH, or 6 months of Dynogest, and then come in for surgery, and the results, believe you me, will be good, because if you've got no blood around to play around, to worry about, then your dissection becomes easier, and the healing also is quicker, and the results will be better. So then you come in for the third step therapy, because then there are bound to be adhesions, so you're going to clear them off, and then you can get rid of all the nodules that are hanging in there. The medical treatment never abolishes endometriosis, only suppresses the disease, and therefore you need to be surgically active to take this on. Right, so again, this is from Human Reproduction, photographs put by Donay in his article. Basically is doing exactly what Sem did 20 years earlier than what he reported, and this is the way they go ahead and carry out the treatment. Right, so let's look at ovarian reserve following surgical excision of the endometriomas. Garcia et al. Showed that the rate of spontaneous ovulation was lower in patients who had undergone surgery, that the levels decreased after surgery again by the other authors, and that the responsiveness to hyperstimulation is reduced. Others said that the number of developing follicles and the number of oocytes retrieved in the operated gonad are halved compared to the contralateral intact ovary. So there's evidence that shows that badly done surgery could result in disaster, which is known anywhere. But look at PADOS, and in 2012, where they studied the residual ovarian volume, they looked at the ovarian vascular supply, and they looked at the antifollicular count, and this is where they compared cystectomy with three-stage therapy, and they found that the ovarian volumes and the vascularization were comparable. The functional ovarian tissue, as determined by the ASC, was higher after three-step therapy. Right, so then the Japanese group looked at anti-Mullerian hormone levels after laparoscopic cystectomy for endometriomas as a possible predictor for pregnancy, and they assessed preoperative and postoperative the serum AMH levels and endometriosis surgery for endometriomas with the success of infertility treatment after cystectomy. And out of the conclusion was that there was no significant difference in the serum AMH levels at any time between recurrence and non-recurrence group. The serum AMH levels 1 year after cystectomy for endometriomas may predict the success of postoperative infertility treatment. However, it does not show a recurrence of endometriomas, does not predict a recurrence of endometriomas. The Chinese group then looked at the AMH trend after laparoscopic cystectomy and ovarian suturing, because now everyone wanted to see how they can limit the damage and improve the ovarian reserve. So they looked at these two groups, and that the changes of the AMH and FSH values suggest that the ovarian reserve is obviously reduced in spite of ovarian suturing technology used as a method of achieving hemostasis after enucleating of the endometriomas. So therefore, when you have to coagulate, you should also, the tip is that you need to irrigate and coagulate simultaneously. Just don't go on coagulating in the dark. Coagulating normal as well as abnormal. Michel Canis also mentioned where he just used the bipolar, and it was his own personal case. He just used the bipolar for a few seconds, and the patient ended up with an ovarian failure. So therefore, you've got to be careful, especially when you're coming down towards the hilum in trying to achieve hemostasis. Right. So Asghari and the Iranian group then looked at comparing the ovarian reserve after laparoscopic excision of these cysts and hemostasis that could be achieved either by coagulation or suturing. So they found that the impact of surgery and hemostatic techniques on ovarian reserve was evaluated using AMH and FSH assay preoperative as well as 3 months. That was the way they did. And they found that at 3 months post-op in both the groups, the AMH was significantly lower and the FSH was higher than before surgery. However, the decline in the rate of the AMH was significantly more when bipolar was used as against suturing. So there is therefore a definite role of suturing in their series, and that the patient in the suturing group had a higher AMH and a lower FSH as compared with the other groups. Right. So then we have my good friend from Taiwan, that is Taiji Song from Kaichung, where he used the hemostatic sealant which was flow seal in preserving the ovarian reserve. So he felt that the use of a hemostatic sealant instead of bipolar should be considered, as it has benefit of preservation of the ovarian reserve, except that flow seal is available here in India, and it's fairly expensive for some of the patients. It's almost about 10,000 rupees for just one little ampule that's available. So this is something that we need to look at. And then they looked at, when Muizi compared the stripping technique with the combined excisional and ablative technique for treatment of bilateral endometriomas, they found that there's no evidence that the combined excision and ablative technique is better than the traditional stripping technique. A similar recurrence rates were observed with both the techniques, and that's the article that they had in the Human Reproduction. Once again, they looked at, the Chinese group now looks at 70 patients who had endometrioma surgery, either unilateral or bilateral. The hemostasis was achieved by the suturing technique. They looked at the ovarian reserve, evaluating the AMH, the FSH, the ovarian volume, and the OSP index, and the resistant RI on day 3 preoperative, post-op 1, 6, and 12 months respectively. And this is what they did find, that there was no detectable difference on the ovarian reserve marker levels between the 4 groups and from the baseline levels at 6 months and 12 months after enucleation of the endometrioma. So this brings us to the technique that we now adapt, and this was described by this gynecologist. She is from Japan, Seiki, and she has now had further more updates on her work. This was her work from 2010. She again gave further reports on her work in 2019 at the last conference of the A-Page, where she used vasopressin, and she's got a very nice video. So if you look at the JMIG, you will see her video that she employs during her laparoscopic excision of the endometriomas using diluted vasopressin. Now, vasopressin, fortunately, is very readily available like water in India, and both in Bombay and Hyderabad. We are very lucky that we can still use it, though it's been banned by many centers in Europe as well as the United States. But it was earlier started with Professor Sem, it was called as POR8. The same thing, vasopressin comes as a unit ampule of 20 units in 1 ml, so you need to dilute 20 units in 200 ml of normal saline. And if you use this diluted form, whether you use it for a myomectomy or for an endometrioma, you do not really have to worry as long as you have not punctured into a vessel. So you need to aspirate to check that you have not gone into a vessel, and then you inject, and then you will have great results. And as they showed, that it reduces the use of coagulation, and if you have to use less of coagulation, then obviously you are going to protect the ovarian reserve, right? So I'll show you this video that we used on our patient of vasopressin. We used the SEM vasopressin needle. So you need to aspirate and then inject. So it does require multi-ports, so you require 3 ports in addition to your telescope. So this is a fairly older video, about 2 years old, and therefore we were still using monopolar, but now with the new bicutter that is there with the locally made one, it has actually completely replaced. I stopped using even the harmonic, even during a myomectomy. You can use the cutter. It's a reusable autoclavable device, so it's much easier to use, what Kadambari showed you in her video, right? So basically you can just go on cutting, you just use scissor. Right, I will fast forward this a bit. Right, and then once you get into the proper plane of cleavage, you can just go on separating out. See, everybody has weaknesses, including adhesions, so therefore you just need to wait, be patient like a wolf, to wait for the right plane to come your way, and then you dig inside and you separate out. You see that then you have the normal and the abnormal, right? So you can then just move, just traction, and the tissue just move away from each other. Incidentally, this is the same technique that we even employ for our dermoids. We use vasopressin to help us to enucleate the dermoids, so the dermoids can come out intact. There's no bleeding or hardly any bleeding, and you just selectively coagulate whatever bleeders may be there using a bipolar, of course with constant irrigation, to see that you have been able to achieve hemostasis. So you just pinpoint, coagulate, and that's it. And then at the end of it, you can suture. Right, so prior to enucleation, in summary, you would inject vasopressin till you get a good avascular display, and then you go on enucleating. And if the margin is wide, you need to approximate with sutures, and just take one or two simple sutures. Right, so this is the way we do it. Right, so when we looked at another series from Fertile Sterility by Telek, they found that the AFC increased significantly at 6 weeks and at the 6th month. The FSH increased significantly at the 6th week, but returned to normal after 6 months. The serum AMH decreased significantly at 6 months post-operative. That the AMH decrease was more in bilateral compared to unilateral endometriomas. AMH decrease was more in those endometriomas that were less than 5 centimeters. Right, so then you have Alan D. Cherney coming back again, and he said that the infertility surgery is dead and that only the obituary remains. So therefore there's going to be this constant fight between laparoscopic surgeons and ART surgeons, saying that mine is better than yours, and therefore I can get everybody pregnant with ART, and there's no need to do laparoscopic surgery. The patient continues to linger with pain, and she's hobbing. There's a potential divorce coming up because of pain, and the husband can't enjoy his sex life. So therefore these are things that need to be addressed. And if you're talking about empowerment and empathy for women, these are things that women gynecologists should also look at, other than just trying to get people pregnant. Right? So whatever practices that the ASRM, AHRA, you have to look at reality, because there are 4 types of lies: damn lies, IVF statistics, and success rates with endoscopy. Right? But then there are 3 truths: the truth, the whole truth, and nothing but the truth. And I end up with my last slide with Marilyn Monroe. She wasn't killed by, so that's again a lie that the FBI killed her. FBI did not kill her. If you look at endometriosis, the Association Endometriosis International, they have shown that she had rectovaginal endometriosis. She was ODing on morphine rectal suppositories. So it's not John F. Kennedy or Robert Kennedy who did it, or Edgar who or whatever, but it was that she she had 2 laparotomies for endometriosis, and the pain continued. Her X-ray chest that was taken preoperative by her GP was 20 years later sold for $60,000 for reasons that are best known. And so endometriosis continues to remain an enigma. Thank you, ladies and gentlemen. Thank you.
Nice videos as usual.
Let's do this thing.
They now
Yeah.
invite Dr. Axel,
That's correct.
Dr. Axel Foreman, Dr. Sultana will read out his.
Do you have the hits?
No, you do it.
Reading out is not my favorite job. What comes to my mind is. First of all, Dr. Prasant, thank you so much. A picture is worth 1,000 words. You proved it, because always it's very, very good to correlate with pictures and the practical work that is going on. Thank you very much, Prasant, once again.
Thank you.
Prasant has been known to Hyderabad since a long time, and I should acknowledge that he was introduced by Dr. Mamatha Shinoy, and then he is a very familiar figure in Hyderabad for everything. We used to collect cases those days. You remember, Mamtu? We used to collect cases those days, and then Prasant would come every 15 days or 1 week or a month, and then we...
I know. I must make two comments on this. One is, like Martha said, you come to Hyderabad in 1992 like a period. Of course, it's nothing to do with, it's not a regular cycle, because it all depends on Bharti out here, who looks at the moon and the stars and then and the other one was another gynecologist here many years ago. She's not here in the audience. Said, "Tu चोर की तरह इधर आता है, पैसे करके चढ़ा जाता है."
पैसे लेकर भाग जाता है बोलते थे हम लोग इसको, लेकिन बहुत काम करता था, and we did not leave him. I followed him, pursued him, and even to Oman and Muscat he was called when I was there. Right, Prasant?
I invite all of you all this August on the 6th to the 9th. We have a conference of the APAGE, the Asia Pacific Association of Gynae Endoscopy, which is being organized by Korean
Axel
journalists.
Foreman.
So you'll all receive the invitation. The brochures are being released shortly. But be there and present your work on endoscopic surgery. And also at the same time, I take the opportunity, that is Professor Axel Foreman will invite you to, there are brochures here that have been brought and being distributed. We have a brilliant conference being organized by him of the ISON. The ISON is the International Society of Neuropaleology, of which he is the president. And this is in Aarhus, Aarhus in Denmark. And I'll be there, so you all guys should be there. Yes.
Nice presentation, always. It's a pleasure to listen to you. Two questions. No, that's fine.
He's loud enough.
I'm loud enough. Two questions. One, do you always use suprapubic board, or was it?
In endometriosis, I now use the suprapubic because it's more ergonomic to go that way, especially when you are dealing with the nodule. But I wouldn't mind taking one more puncture up there, so it doesn't mind. 5 millimeters, it's not really going to cause a problem. Taking an additional the pose point.
Second, you showed that you train in ovarian suspension.
Yes.
Now, in those endometriomas, most of them which are stuck to the pelvic side wall, you release them, do endometrioma stripping, and then when you leave back...
I don't do the stripping before I do the I first do the rectovaginal.
Yeah. In those who don't have nodule, for example, it's only bilateral endometriomas.
Then you don't have to suspend it.
Yeah. No, but what do you take any special precaution to make sure that it, you can't make sure, but to prevent or reduce the, minimize the risk of adhesion again to pelvic side wall? Do you do something, adhesive-lytic agent?
Barrier like Intercede.
Second, sorry?
We use a membrane barrier like Intercede.
Right.
Yeah,
but
there's no ideal membrane
adhesion
barrier as such or anti-adhesive device as such.
Right.
You will probably use the holy water from Patanjali also.
Try that. No. Do you tie the ovary, suspend the ovary for a few days after surgery to cut it and then later come back?
Patanjali does that in England.
Yeah.
But I don't suspend because he calls them back on the 5th day.
And then cut it and then it...
Yeah, but that used to be done even by laparotomy long time ago. But I don't know whether it's evidence-based.
No, we used to do that, that's why I'm asking. I mean, we used to do it in UK with Professor Jeremy Wright. He was probably one who was doing it. Thank you.
Thank you, Dr. Prasant, once again. So he is popular, he is famous, he is very good in his work. All those adjectives he deserves. And thanks to Mamatha for introducing him to Hyderabad. It is yes. And of course, we should always acknowledge all these things we have learned from Kurt Sem. He used to come so regularly. Bombay was his second home. And we were so awe-inspired by him that one day I said, Dr. Kurt Sem, the only thing that you have to do is go from the peritoneum and reach the tonsils and remove through your laparoscope. Because he used to do everything through laparoscope, so easy. Coming to Dr. Axel, I know I'll use only 4 words to introduce him to you. Of course, he is very prominent, he is distinguished. That's why he has been invited here by Dr. Mamatha. He is a clinician, he is a researcher, he is a co-editor, and he is the best laparoscopist, isn't it? Who gives, everything what Prasant has done, Mamatha has done, and anybody has done may be forgotten for a little while, but when he maps the pain and relieves the pain, he'll be remembered always.
Thank you very much for your kind presentation. This is my first time in India. I'm really impressed. I'm impressed by the scientific level. I'm impressed by the colors. I'm impressed by the food, and not least by this friendly way you approach people. Thank you very much. I love to be here. I'm going to speak on neuropelviology. I think it is unknown to most of you, but this is a systematic approach to pelvic pain and organ dysfunction. I will come on to advanced endometriosis sometime during my presentation, but this was my task from the beginning here. I'm president of the International Society on Neuropelviology, which is a new organization that has focused on this issue. This is my university, and I have no disclosures. So, just to raise your attention, what would you do here? 23 years of age, and it was my own patient. I met her at the operating theater. Laparoscopy 4 months ago with resection of stage 2 endometriosis. And severe pain in right side since then, repeated emergency visits with similar attacks. And now extreme acute pain in right side. Gynecological exam difficult, normal findings in vaginal ultrasound, no hernias, normal biochemistry, and she was scheduled for emergency diagnostic laparoscopy. Axel, couldn't you do it? We don't know what to do here. You need to do it. She needs to have an expert laparoscopist. What would you do? And I can tell you that 10 years ago, I would have done the laparoscopy due to suspected torsion, something like that. This is what happened today, or at this time it was 2 years ago. I met her just before the anesthesiology started, and I examined her with a cotton swab, and she had allodynia in the right fossa, with a trigger point at the right trocar incision. Just here, you can see the scar here. So next thing there was that I cancelled the surgery, and her father was with her. She was very suspicious, and now he was furious, and the patient was crying. You stopped my surgery. I cannot be saved here. But then, half an hour later, at the patient's department, I gave her a blockade with lidocaine, and she was pain-free, totally pain-free, after ultrasound-directed subfascial blockade. So now the patient was calm, and the father was suspicious. But now she is doing well after repeated combined local Botox, 100 units every 3 months something, combined with capsaicin patch. Now the patient is happy, and so is the father. But I'm so happy it worked because he could have killed me. I was a very big man. So this just illustrates that pelvic pain was a black box problem in the past. If we had a normal laparoscopy, then nothing was wrong. Pain was the same as psychosocial problems in these patients. And we all know them. This is a well-known syndrome in all pelvic specialties, and patients are left with symptomatic treatment. Now, neuropelviology, that is a neurological and neurosurgical approach to pelvic pain across these pelvic specialties. And I cannot go into this without mentioning our friend, Mark Possover, the founder of this specialty. He was the first president of our society, and he is director of the Possover International Center in Zurich, Switzerland. We owe him a great thank you, also here from India. So the basic platform in pain is a precise diagnosis. and pain is a neurological symptom. So why not a neurological approach? First thing to recognize that we have two pain systems. We have the somatic pain system, that is a system that supplies the skin and the muscle. This is a very precise system. You know exactly where you have the trauma, and you can take away your hand if you cut yourself with a knife something. And you have the visual pain system. This is a much more imprecise system. You don't know exactly where the focus is. So, and this reflects huge differences in neurophysiology. So the first task is to make clear to yourself, do this patient have a visual symptomatology or does she have a somatic symptomatology? Differences are listed here. History, typically visual pain is a gradual start. Somatic typically starts with a trauma. Character pain, visual pain, on specific and dull, think of the start of appendicitis. When pain walks down to the McBurney's point, it is due to activation of the somatic system, which is in the pelvic, anterior pelvic wall. Radiation is unspecific in visual pain and very specific in somatic pain. Concomitant symptoms, patient feels sick, fatigue, malaise, nausea, such things, but very few in somatic pain. The site of lesion can be defined as clinical examination in most cases in somatic pain, but very rarely in visual pain. So therefore, the imaging, MRI, ultrasound, that is confirmatory in somatic pain, there you typically have found the focus when you do the clinical exam, but you need it if you deal with visual pain. So therefore, first thing to see here, the very first thing is to learn to examine the patients seen from this neurological point of view, and then second is to have a very good, very specialized radiologist with you, especially for the MRI. In Denmark, gynecologists perform the ultrasound themselves. Then we need to know something about pathophysiology in the pelvis. And I know we are a little short of time, aren't we? So I'll just jump over a couple of slides here. But this is a really turning point in our understanding here. It is from the Karen Berkeley group in Florida. She put mustard oil into the colon of rats, anesthetized rats, and she noticed then, and then she injected Evans blue into the vascular system, and then extravasation of this Evans blue then reflected the inflammation induced here. And of course then, severe inflammation in the colon, in the rectum. That's not surprising. But what she saw was that there was also inflammation in the bladder and in the uterus, so that in a way the colon corresponded with these other organs. She had distant inflammation, distant to the local inflammation. And they also saw that if they transected the hypogastric nerve, which is the visceral nerve, the autonomous nerves, then she could prevent this reaction here. This is what is called cross-organ effects, which means that we have a disease, an inflammatory disease in one site, in one organ. It will spread to the other organs via the visual nervous system, the autonomous nerves. Cross-organ effects. That is the first very, very important thing to consider when we talk about pelvic pain. Then the next thing was that this same group developed the endorat, the endometriosis rat. Now they implanted endometriosis onto the mesenteric vessels of the small bowel. This is far away from the pelvic area. And these endometriosis implants, they developed into endometriosis lesions very much alike human endometriosis. And then they looked at vaginal pain threshold. They inflated a vaginal balloon in the vagina, and they looked at the pain reaction. And they did it in a very elegant, objective way. They started pinching the tail, and learned the rat, if it was in this cave here, that when it moved the nose, then they stopped pinching. The rat rapidly learned to move the nose then. They then inflated the balloon in the vagina, did the same thing. As soon as you move your nose, then we stop inflating. It rapidly learned to move the nose then. So this became an objective measurement of vaginal pain threshold. Then look at what happens here. This is inflation, and this is the number of rats, proportion of rats that started moving the nose here. And this is before surgery. Then if they implanted endometriosis and they waited 3 to 4 weeks here, then the rat reacted earlier. So this decreased the pain threshold in the vagina. So distant endometriosis made allodynia, made a local pain response in the vagina far away from the endometriosis lesion. And then third thing was that if they removed the endometriosis, then this reaction went back to normal levels. That was first lesson or second lesson. But the third lesson was that if they made a sham operation, so they operated the animal, but they left the endometriosis in place, then the rat became more pain. So insufficient surgery further damaged the rat. So, first, endometriosis communicates with the pelvic organs, even when located distant to this place. Second, removal in the early phase can normalize this response. And third, if you do insufficient surgery, this will worsen the pain. And this in the simple way, this reflects why patients have such severe deep dyspareunia, despite that the lesions have been taken away. This is simply got chronic. And the explanation is then that due to this what we talked about before, this imprecise nature of the autonomic innervation means that you have a huge afferent activity from these lesions, but this spreads diffusely to the lower abdomen, so that you have maybe then sensitization in a lot of places, and they showed that this was actually the pain in the rectum, in the vagina, and in the urethra. And they also have a decreased maturation threshold. They got overactive bladder. We know this from our patients, don't we? Then we should consider a third thing, not only cross-organ effects and distant alterations in pain threshold. This is from Cathy Vincent's group in Oxford, I think she is. And she looked at patients with isolated severe primary dysmenorrhea without any suspicion of endometriosis, dysmenorrhea only. And then she looked at the peripheral somatic pain threshold. And she could show then that even in the somatic system, this patient had a decreased tolerance to a specific pain stimulus. So even if you have patients with isolated dysmenorrhea, these patients are sensitized in the somatic system. So the message here to all of us and to the general practitioner is dysmenorrhea must be treated. Don't let your patients go with dysmenorrhea. And they explained this very elegantly in a series of MRI studies where they could show that this sensitization, this low pain threshold, corresponded to both abnormal activation in the cerebral area with pain sensitization, but also a loss of inhibitory centers in the brain. So you could see in these patients that they were sensitized. They both lost their inhibitory pain stimulus and they had an exaggerated pain response. What are the clinical correlates here? Well, then of course, this explains the deep dyspareunia seen in our patients. They don't need to have endometriosis in the retrovaginal area. They simply have been sensitized and have a chronic pelvic pain. This is what characterizes chronic pelvic pain. It is a neurological disease. They have an increased risk of abdominal pain syndromes, increased risk of overactive bladder, painful bladder syndrome. They have a decreased somatic pain threshold, pelvic floor tenderness, increased risk of polymyalgia. So what we learn from here is to avoid repeated surgeries and to avoid painful periods. And so direct clinical consequences is that when low-risk medical treatment fails, and with this I really mean that even in advanced endometriosis, and very importantly, if you have no organ affection, this means that even you have a nodule. In our experience, in our clinic, and we have the largest endometriosis center in Scandinavia. It's nothing compared to this area. Scandinavia, that's 20 million people, something. We are in an area of 100 million. No, I'm lying flat down. This is much bigger. But our approach is that if you have an isolated nodule, even with bowel affection, if you reach your goal with medical treatment, you should do it, because you do have complications to surgery. But then especially if you have organ problems, which means urethral stenosis typically, or your low-risk medical treatment fails, then you must make radical surgery, and you should do it in one step. So radical removal of bowel endometriosis, you do your bowel resection if needed. Of course, preservation of fertility, and take the risk of complication into account. And very importantly, preserve the pelvic nerves. Avoid multiple surgeries because there is a risk of further pain. And then after surgery, take into account that your patient is typically sensitized. This means that he has an increased number of sensory nerves in the endometrium. So you cannot expect dysmenorrhea to totally disappear. She is sensitized. So therefore, in our opinion, we always get the patients use continuous oral contraceptives or the liver-nourishing IUD post-surgery to avoid the painful periods, because this will further worsen the situation. And if this is insufficient for amenorrhea, we continue with Provera and Bisan, of course. Still pain despite this approach, and still pain despite standard analgesics. Think of this horizon with other diseases. These patients have an increased and severely increased risk of irritable bowel syndrome, as the first speaker very carefully mentioned, very nicely. And this is due to, of course, then, a decreased pain threshold in the colon, which we know they have. That has been proven. Dietist, FODMAP diet, so on. Take care of the pelvic floor tenderness. This is a somatic consequence of the sensitization. Physiotherapist. Then consider actually psychotherapy. This is not to say that this pain is psychosomatic. Every pain is psychosomatic. You cannot be in pain without having affection of your personality. Of course it's psychosomatic. It's not the same as to say that these patients don't have a biological cause of the pain. But it works. We did a study on mindfulness-based psychotherapy, and we could show that 5 years after this session of, I think it was 3 months and with 10 sessions, 8 of 10 patients still used methods. So it is very usable to the patients. Of course, there'll be something about your lifestyle. And then for analgesic treatments, avoid opioids. And if you cannot do with NSAIDs and paracetamol, then consider using these pharmacological approaches to blockade a spinal and cerebral pain, gabapentin, pregabalin, the SNRIs, the TCAs. Because these, the evidence is not really good, I have to say, in visceral pain, but there is some evidence that they block pain transmission both at the spinal level and the cerebral level. Both gabapentin, pregabalin, gabapentoids are they called. Dose is limited by side effects, sedation, weight gain. Start very slowly, and ideally combined with 3-cyclic antidepressives or the selective noradrenaline reuptake inhibitors. Antidepressants, this effect is independent, the antidepressive effect. Some patients are reluctant to use these drugs because, well, I'm not depressed and so on. No, you're not. It is explained to the patients that it is another side of this drug that we use here. It may work, and it may work if you're depressed, but that's not what we are going for here. And then usually they accept it. It has a slow onset of action, but it is faster than the antidepressant effect. And then also here, start low. My favorite drug is duloxetine. In my hands, this has the lowest frequency of side effects. If this doesn't work, then if this is available, you could think of pelvic neuromodulation. And there are lots of nerves that have been tried for neuromodulation. In general, it is the nerves that contain the sacral roots up from the sacral plexus. The S2, S3, S4 roots. Of course, this is what these nerves have in common. You go directly for the roots, you can go for the dorsal genital nerve, you can go for the pudendal nerve, posterior tibial nerve. The sacral roots nerve stimulation is the most accepted and most used and where we have the best evidence. And these are patients with chronic pelvic pain, and they have been followed for actually 3 years with quite a useful decrease in pain. Maybe in the future we will have laparoscopic pelvic nerve stimulation. This is what is under development in our society, especially with Mark Possover, where we go for laparoscopic application of electrodes to this area where the sacral roots communicate with the autonomous nervous system. And when you are used to go here, it is not that difficult actually. Now we go to the somatic pelvic pain. We have been through the visceral pain. This is the other pain system. And this is the area where classic neurological examination leads to precise diagnosis. Here you should change your mind, so to say, to old school neurology. This looks messy and looks very messy to me when I started. Actually, I had to teach anatomy to medical students for half a year to get back into anatomy, and it was a hell of a work to do it. I had to read like, I don't know how I got through it. But really, it might be good for you, and I did that for a long time, simply have these forms besides you in your office, so that you just, well, this is this nerve, this is this nerve. It is a classic diagnosis. It is based on your pelvic anatomy and pathophysiology, and you require a detailed examination of the sensory function. Remember the patient here. This was exactly what was done here. I was lucky that I thought of the iliohypogastric nerve, and I realized that the incision had been done exactly where this nerve enters, just below the fascia. And even though we learned that we should always incise 2 fingers above the spine here, this is typically done when the abdomen is inflated. And then this point raises up here. And this is why we see these patients. And this is the most frequent lesion I see in my pain. I have a pain outpatient clinic where I see everything that goes wrong for my colleagues. And but I see this as my task actually, since as I remember the old days, it is awful to have these patients coming, and that's somebody who can relieve your colleagues and take them over into a special setting. So that's what I do here. And the cotton swab here, it's indispensable. It's not a very expensive instrument, but it's very effective. Then remember the difference between peripheral and radicular radiation. So if you have a process on the root, you will have radiation to all along the dermatome. as opposed to the peripheral affection, then you have radiation to the area which is innervated by the nerve. These are two very different situations. And these and the division into visual and somatic pain, this is your clue to your diagnosis in the patient's history, together, of course, with a detailed history of operations, traumas, deliveries, and so on. We start with what I'll call abdominal or above knee radiation. This is the radiation that is typical for the lumbar plexus. The roots of the lumbar plexus are covered by muscle. This is rarely a problem we meet in our clinic. So these are the peripheral nerves here. The genitofemoral nerve, the observatory nerve, the iliogastric nerve, and so on here. Then look for peripheral pathology and ask for relevant trauma. And by far, as I said, the most common is the neuropathology associated with laparoscopies and laparotomies. Look for dysesthesia, decreased sensibility, and allodynia, and then the mapping will lead to your diagnosis. Let's just take a short review of each of these nerves. The iliogastric, ilioinguinal nerve, C-section, laparoscopy, hernia repair. Look for allodynia, and the trigger point, very important, because this is where you would put your blockade. Do this with ultrasound guidance so that you are sure that you place your blockade exactly below the fascia. And for God's sake, don't go intra-abdominally, because then it's quite another thing there. And maybe start with steroid plus the local anesthetics. And in some cases, this works quite good. And if it doesn't work, then the local therapy is Botox, and it works quite good. And combined with the capsaicin pad, India capsaicin is very much of your spicy foods is spicy due to capsaicin. Yes, it's good. If no effect, you might consider neurectomy. You might consider radiofrequency ablation or cryo, such things. You do have a risk of pain recurrence in these cases. Femoral or genitofemoral neuropathy, the femoral branch of the genitofemoral nerve should this be. Think of this, for example, if you have a patient that has had a urethral lesion, then you may have a neurologist who did the psoas hitch, and there you may have to make neurolysis. Can happen also during C-section and laparoscopy. Then you have the below knee posterior radiation. This was typically anterior radiation. And then you should think of the sacral plexus. Below knee radiation corresponds to the S3, S4, S1, S2 here. It can also be S2, S3, S4 with the pudendus. Look for the specific radiation, a specific muscle weakness. Look at the patient walking, sensibility, allodynia, and then you will get a detailed picture of what's wrong here, and then ask your radiologist to look for specific areas. And this is such a patient here. Look at this vessel. You have the sacral root here. You will have the lumbosacral trunk up here, and this is an abnormal vessel making vascular entrapment. This is a typical lesion here. And you may also then find the sciatic endometriosis. Sciatic endometriosis in our setting is rare. We had 2 to 3 cases per year with need for surgery in Denmark. But in India, with your huge population, you should see 800 cases something. You should see that. And of course, there are population differences, but it might be that these patients are ignored. I have the first patient I saw here. That was a young. She was a student in psychology. She did a bad study. She was invalidated in pain, and when we saw her, she was. We couldn't make her pain-free. She was really crying. So we could hear it out on the outside of the hospital. And we soon realized that we saw her during menstruation that there was a severe affection of the sciatic nerve. We had a confirmatory MRI. We couldn't do it in Denmark, and I contacted the Danish National Health Institute, and they said, well, that's okay, we have a special funding for this. And so I went to Mark Possover. That was my first contact. And he made the operation. I was there, and today she is a PhD student in my team, actually. And I'm allowed to tell about it. She has accepted. So, and just to show you what we do here, sorry, that didn't work. There we are. No. There we are. There we are. This is just to show you our surgical approach here. This is the access between the external iliac, the pelvic side wall. We have the genitofemoral nerve here. You have the lymph nodes here. Up here you have the internal inguinal canal here. You go down here. This is the obturator nerve here. There, obturator, and then just below here, just a minute. There we go. This is the lumbosacral trunk here, and after it receives the S2, S3 mainly, it becomes the sciatic nerve. And just to let us just see what are the surgical difficulties here, you can see that everything above the lumbosacral trunk, between this wall here and the side wall, can be coagulated. But be very, very careful when you reach down here. And I would say don't do it without special education. It is not just to do it. We return to education this area just in a minute here. See that here we have an obstacle. Here it should divide easily here. It doesn't. And this is where we divide it. This is the sciatic nerve here. And this is a nodule here. And we have to free the nerve of this nodule and then to excise it afterwards. And this is just to show you the principle here, that you need to be very careful to the nerve. We then excise into the muscle here. You have to avoid the vessels here. But in order to have radical surgery as far as ever possible here. That's it. And just we continue here. There we are. And there comes the vessel. This is combined endometriosis. I think we also had a vessel here. That's it, yes. Just to show the principles here. So this is, in my opinion, where specialization is really, really needed in endometriosis. In my opinion, if you talk about rectal endometriosis, you should do at least 30 cases, yes, something, 20, 30. Because it's so important that you have the routine. And you really, really have to have surgeons like Prashant and his son and such guys to do it, because surgical experience is the turning point for these patients. So that's where everybody can see that you have to collaborate. I would say that, but I would also say then that bowel endometriosis must be the platform that where you are, you know where you have routine before you start here. So endometriosis surgeons are those who are best in this neurosurgery. it is, in my opinion, not the way to go to then invite your neurosurgeon into the field, because they have no experience in laparoscopy, and you need to do this laparoscopically. It simply cannot be done in open surgery, which I think they would prefer in some cases. So you may invite them to come to be there, but it should be the endometriosis surgeon who does the work actually. That's been our way to do it, and I know really of no one else who does it in other ways here. Then this is just to show you at the end of this day some further developments of this technique. We have the Skyline project. This is the spinal cord injury project, where we applied then electrodes to these nerves, just to show you the future. This is where we then apply electrodes in patients that have paraplegia in order to restore motor function. So we apply electrodes to the sciatic nerve and to the femoral nerve, which is here. And this just shows you the future potential of this new combined neurological and neurosurgical approach, which is neuropelviology. Now we have electrodes on the femoral nerve and on the sciatic nerve here, and we have then a subcutaneous pacemaker in the right fossa here. Sorry. And this is what happened to the patients within 6 to 12 months. This is the first time this guy is standing after 12 years in a wheelchair with stimulation of the nerves. And, you know, he was really, really, really happy. He was really happy. And then, next thing is that after years, see this patient here. It is, you can see, it is not a ballet, it is not a marathon, but he is standing with himself, and look here, some walking. That's nice. So, the potential of this new technique of precise diagnosis combined with a surgical platform where you can reach these plexuses has a huge potential. We have seen new possibilities to apply electrodes for control of pelvic pain, maybe control of bladder function, maybe control of bowel function also, is complementary to the usual sacral nerve stimulation, because here we can reach all the pelvic nerves in one procedure. We can see here, and these patients, they tell us that the stimulation of the sciatic nerve here helps them with their hyperactive bladder. My last patient told me, well, it's not that much by standing, but I am so happy that I don't pee my trousers. That's very important. So, sorry. I understand if you feel frustrated here. Your anatomy and mine was so physiology and neurology, they are far away. But there is help is available. We have the society, International Society in Neuropelviology. You can just go there, not just, it's a hell of a work here. But we have an education program here. Level 1, the diagnosis. Level 2, the detailed diagnosis and introduction to surgery. And then, of course, the master level. And the level 1, studies at home. You don't need to go anywhere. You just buy the book, and it is included in the course fee. You have an internet-based test, and it is a very good platform for diagnosis. Level 2, you go to a meeting, can be in Aarhus. We'd love to see you in Aarhus. There we have cadaver dissection and a comprehensive course with diagnosis and treatment. You must pass the level 1 test. And then the expert level is for those who are attached to, who have a center function, who will start with the spinal cord injury operations, development of multidisciplinary team, and scientific contributions. The pitfalls are: be humble in this area. Don't do more than you really think you can do. Don't promise too much to the patients. Never promise a patient to be pain-free. You cannot. It's impossible. Involve your colleague specialists, neurology, neurosurgery, pain specialists, spinal cord injury center, and so on. And yes, I just remind you that you have an expert neurophysiologist amongst you. This is Prashant. Prashant is the Iceland director of international development in our society, a very, very important person and a board member. And he's really good at neurophysiology. So if you want to go this way, discuss with Prashant. Save the date. We are having a World Conference in Aarhus in half a year, September 17 to 19. I'd love to see you there. Such nice colors in our great country would be so fantastic. So thank you very much for your attention.
Thank you very much, Professor Foreman. I think they have started sacroneural modulation here for bladder problems. They have done it. It is available in India. I have seen that urogynecologists are using it. And I think it's fascinating, fantastic. I think, you are reaching new frontiers in this by going to neuropelviology. Congratulations, Dr. Prashant, because you are the representative. I think you have to take it forward in India. Thank you very much.
Thank you very much.
Dear Mamtu, thank you so much for giving all of us and on my behalf this opportunity of such wonderful, invigorating updates that you have organized. And thank you so much for the speakers for showing us the hope that technicity can improve quality of life. Thank you so much.
Ma'am, thank you. Thank you to the chairpersons who made this, whole session so much of fun. One was classy and crispy, and the other one is bold and feisty. So it was lovely having you all. Thanks to all the delegates for being here. Thank you to all the speakers. They all were brilliant, outspoken, and very knowledgeable and imparted so much of useful information for us. I want to also thank the team of Mamatha Fertility Hospital who helped us organize this whole event, and because we've been bombarded with so many conferences of late, we decided that we want to make it a unique and focused and a small closed door meet for selected doctors who would be interested in this subject. And thank you to Bayer ZYDUS and the whole team of Bhaskar for putting this event forward. Thank you so much for being here, and we'll continue to organize such focused events. Thank you. Please, just one last thing, I'm sorry. Can I just ask our team members to, as a token of our appreciation and gratitude to the speakers, just present this token to the speakers. Dr. Bharti, can you just come forward? Dr. Surbi and Dr. Kiran. Dr. Bharti, can you please hand over the token to Dr. Kadambari, Dr. Surbi to Dr. Prashant, and Dr. Kiran to Dr. Axel. Thank you and good evening. I request everyone to stand in attention for our national anthem.
भारत भाग्य विधाता
पंजाब सिंध गुजरात मराठा
द्राविड़ उत्कल बंगा
विंध्य हिमाचल यमुना गंगा
उच्छल जलधि तरंग
तव शुभ नाम जाने तब शुभ आशीष मांगे गाहे तव जय गाथा
जन गण मंगलदायक जय हे
भारत भाग्य विधाता जय हे जय हे जय हे जय जय
Jai Hind.